First, we're going to have the invocation by Counselor Frankie Hargis.
Self-stand. Heavenly Father, we thank you for this day. We thank you for the rain that you blessed us with last night. And Lord, we just ask you to bless this meeting and to guide and direct our thoughts and our decisions. In Jesus' name I pray. Amen.
Ms. Shelley, call the roll for us, please.
Janelle Fulbright.
Present.
Dick Lay.
Here.
Jack Baker.
Here.
Harley Buzzard.
Here.
Joe Byrd.
Aye.
Julia Coates. Jody Cushionhop. John Garvin. China Glory Jordan.
Present.
Frankie Hargis.
Present.
Lee Keener. Curtis Snell.
Here.
Janice Taylor. Here. David Thornton.
I'm here.
Victoria Vesquez.
Honey.
David Walkingstick. Kara Cowan Watts.
Honey.
We do have a quorum.
Thank you. Next is the approval of the minutes. Do I have a motion to approve the minutes?
Motion. Second.
Motion made and second to approve the minutes. All in favor of the minutes, let it be known by saying aye.
Aye.
The minutes are approved. We'll go right into reports from Claremore, and Mr. Valyers isn't here, and he sent a representative.
Lieutenant Commander Batiste.
Lieutenant Commander Batiste, welcome.
Thank you. Good afternoon. Mr. Valier sent out his report. A couple updates I wanted to give you this afternoon is one on the MRI. It is finally at Claremore. The building's there and the MRI is actually in the building. They're finishing up the construction on the exterior of the building as well as the new reception area for the MRI. We have hopes to begin imaging people in the latter part of May. So that's finally here, and we're pretty excited about that. And we're going to be doing some outreach with our the clinics that we support with on how to refer for that service. And we'll be getting in touch with obviously all the Cherokee Nation clinics that come to our way, and we'll make sure that we can work out a plan to get all of our patients taken care of. We do anticipate a pretty big demand right off the bat, so, but again, we're excited for that. So, second thing I wanted to update you guys on is starting next Monday, we're going to expand our urgent care hours. We have been running just 8 to 4 Monday through Friday, and as of next Monday, we're going to start being open 7 a.m. to 7 p.m. So, hoping we can get some of those people who have to work each day, either before they go to work or even after they go to work, and hopefully cut down on those wait times in the ER. So, pretty excited about those two measures. Entertain any other questions or comments?
That's great. I'm proud to hear that. Counselor Watts?
Thank you, Madam Chair. Thank you for being here today to report on the MRI. First of all, congratulations and thank you. Not we, but IHS, Claremore, the facility, go back and review maybe the last year or two of records where there was denied MRIs under contract health service and ask for them to come back?
All those MRIs that were deferred or denied, yeah, we're going to look at that and see where those people are at. Our presumption is most of those people were not able to get that service, so we'd like to take care of those folks that had the need first and then move on from there. That, talking about between 800 and 900 MRI requests we had, I think, in the last fiscal year that were denied or deferred, so that's a big number right off the bat. So.
But it will be, and those patients will be contacted.
I think that's still in
theoretically.
discussion, but that's what we're hoping for, is to go back and look at those.
I would ask that that be done.
Okay.
I don't know.
I can take that back and
Okay.
discuss it.
Someone let us know next month.
Sure.
Or follow up by email to
Yep.
what the outcome is. Thank you, Madam Chair.
Counselor Lay?
The MRI in operation, will it be 12 hours a day or 2 shifts or?
Yeah, right. Right when we start in May, it'll be 1 shift, and we hope to, in the next 3 months after that, expand it to at least 12 hours a day. we know the need's going to be so great that we're getting people trained up, and at least 12 hours a day is what our goal will be, hopefully by the fall. The typical MRI is about an hour-long process, so, for each hour you're open, you can do one study. So we'd like to get where we can do at least 12 studies a day.
Counselor Keenan?
Thank you, Madam Chair. Good to be here.
Sure.
George, and I was going to ask, good questions have been asked thus far that I was going to ask as well. One other question I had was, if I'm a patient going into Claremore Hospital, and I'm Cherokee, and what's the steps that I need to go through if I'm deferred or denied? Or I guess, how does a patient find out about what to do? What's the next step?
Particular to the MRI, or
No, just in general.
if you're deferred or denied through contract health? If you're Cherokee, if we defer or deny them through our committee, then we send those on, I believe, to Brett to look at the 5% monies, and then I think that's all we do, and then Brett looks at it and see if it's possible for them to pick it up.
Madam Chair, may I ask Brad if he's here? Thank you, Brad. I didn't know if that was, you heard that or not. Oh,
Here's the
okay.
phone, so what was the question?
Well, the steps a Cherokee patient would take if they were denied or contract, if they go to Claremore Hospital, what happens with that?
We run that deferral denial report, we pull those out, and then we filter through our, see if this is,
The Claremore Hospital does contact you, is that correct?
we just pull it out of their system. I have
I
access.
think they have access to our system,
Yeah,
and
we have-
he goes in there and
It's an automatic, behind the scenes thing.
So the calls I get that they've been denied or deferred, you will take care of that?
Yeah,
right?
sometimes there's any number of reasons. Sometimes they're already in the process. Sometimes they have an old address. Any number of things I found. We show Pawnee in the system, and we don't realize they're Cherokee. There's a lot of opportunities to get that thing. That's what we've found over the last year.
I'm sorry?
That's what we found over the last year or so. It's seamless, but it's two systems that are coming together, so it's, system issues.
And so is the system issues going to be addressed, or?
Yes, that's with our efforts to compact those counties, those would be then in our system, so it would remove that level of issue.
So we have to contact the counties first before that happens?
I don't know, we've sent a letter, we've sent our offer to Indian Health Service, and we're waiting to go back to them.
Thank you. Thank you, Madam Chair.
Counselor Taylor?
Brett, would you come back up, because I actually had a kind of a follow-up on Counselor Keener's question.
run away.
They will receive a deferral/denied letter from Claremore, but they're already in the works of our IHS funding, or contract services funding,
Yes.
picking that up. What would be a general ballpark to tell them, give us 30 days, give us 90 days, we can tell them that's an automatic denial, that's something that has to go through in order for it to be picked up on the contract health services.
On a routine, say, orthopedic visit, that's, within 30 days.
Okay,
On an ER call-in, those are ones that, still need them to appeal, because a lot of times it's the first denial is, here's the denial, you need to get your records in within 30 days, discharge, and that, it's really not even considered approval until Claremore does that. So if it's a chest pain and I went to the hospital, that's somewhat different. That's more of a 30 to 60, 90 day kind of thing.
I'm just thinking that we could perhaps save you some legwork if we can say it's just a form letter, it's automatically denied if it has to be looked at under contract health. And so within about 30 days, you should hear from Cherokee Nation.
Yeah.
Okay. Thank you.
Counselor Buzzard?
I want to make sure I'm clear on what Mace County was asking. I thought the procedure was, Brett, and when I get a denial from Fairmont Hospital, then I have to go back and write another letter because of that denial to buy checks. Is that right?
That's for those, for ER call-in type things. For, the motorcycle accident, with that. If it's for like a neurology appointment or follow-up to orthopedic or something, those are different. Those are the automatic ones. So,
I was trying to think, because I used it just recently, and I had to do a denial letter. It's an ortho. But then I got approved at Cherokee Nation.
well, some of those, let's say if it's a Dr. McAllister service, they contact us about every 1 to 3 weeks, depending on, so here's a list of the candidates for surgery.
So that's the
So we then
different
screen those on that. They, one is eligible Cherokee, yeah. We live in the boundaries, yes. We declare more denied, yes. So that's what those are. Those are done to facilitate Dr. McAllister's work.
Well, it gets a little confusing, I could say, at least for the average Cherokee citizen to go through that process, and I was a little confused until you just kind of straightened that up for me. Now, I have a follow-up question, Madam Chair. You talked about urgent care a while ago, and it's good to hear that you expanded that from 8 to 4 to 7 to 7, but my question is, how many providers are in urgent care from 8 to 4 as it is now? And are you going to have the same amount of providers when it goes from 7 to 7?
That's a good question. Right now, we have 3
Okay.
mid-level providers, and we'll remain with 3. We're looking for a 4th.
Okay.
Yes.
That was my concern.
Yeah.
Thank you. Thank you, Madam Chair. Madam Chair.
Anyone else? Counselor Thornton?
Yes. Of course, we've been sitting here listening to this, and I'd like to ask a few questions of what I've heard. First thing, you come out and said that services that you serve 800 to 900 in MRIs.
That's how many we had denied in the last calendar year.
How many of those are Cherokees?
I'd say about 70% of them.
How many are not Cherokees?
I believe
30%?
30%.
How many of the non-Cherokees do you deny?
We've denied almost, I think we approved maybe 5% of MRIs for our own orthopedic surgeons, so pretty much everyone's been denied.
In other words, there were non-Cherokees denied too.
Absolutely.
And what percentage would that be?
Well,
You don't have it with
probably 99% got denied, so,
that were non-Cherokee.
no, 99% total of our patients, so 70% of those were Cherokees.
Funding from the federal government for MRIs?
Not particularly for MRIs. Those are paid for from contract health service dollars, and so they've never met the criteria for us to pay because we always have
Contract service dollars from
contract health service dollars
where?
from the government.
The government, and those are paid by that.
Yep.
Okay. We do receive those. Okay, thank you very much.
Thank you.
I heard this question asked on the other side, but I wasn't real sure what your answer was. On the 800 or 900 that have been turned down,
Yes.
did you say you were gonna go back and pick them up with the new MRI machine?
That's what we've been discussing on how best to do that when we open it up. And so Mr. Watts had asked that we do that, so I need to take that back and see what leadership wants to do, whether we're going to go back or start new. But obviously, we have a huge need that we're deferred in the last year, so you can make a definite good case for going back and picking those up. Although that would put us 800 people on the list right away, so figure figure out how best to do that.
And you think maybe 70% of them might be Cherokee?
Just because 70% of the people that we serve are Cherokees, I would presume that, yes.
So when will you know what your plan is?
Well, we're hoping to start scanning at the towards the end of May, so we've been having MRI meetings each week, and that's something that we have to discuss, so hopefully next week or two.
And when will you let this body know? What
I
you're
can
doing?
either email it to you, or it'll be at this next meeting next month.
I think, I don't know about the rest of the body, but I would prefer as soon as they make that decision that it be emailed to us, and hopefully that decision will include the ones that are in the backlog and not just start with the new ones.
I'll definitely take that back.
Okay.
Let
Thank
you
you
know.
very much.
You bet.
Councilor Thornton, you have no questions?
Yes, I do. Brett? This gentleman said that the ones that were deferred go over to 5%. We have 62 people here from Vanita that's been sent somewhere in their own contract health. How many of those 62%, or 62, go to Claremore?
All of those referrals would go to Claremont.
All of them do?
Yeah, Craig County's,
Okay.
at the present time, all of, not, Craig County, yeah.
Then there's 31 that are there at Claremore that go to Claremore and they're okayed through our 5%.
Correct.
And then Catoosa picks up 26 of those people. They go over there also. Do they go to Claremore?
Yes. Well, I mean, they may go to any number of, they may go to Salina or any of those facilities in that region.
For MRI
Well, for services,
services, right?
for their primary care.
And then Chelsea's 24.
That's where those
Same.
referrals, that's where they live. Where the referrals are initiated is not in there.
But this is all for contract health.
That's for all the 5% part, yeah.
Right. Okay.
And of that,
I'm just trying to get this straight because there's a large percentage.
700, about probably 30 to 35% are actually eligible in that program. So that's correct.
Thank you.
Do you have any other questions, comments? Councilor Baker?
Yes, thank you. So this means that if 35% of those, of the Cherokees have already been approved, then that will significantly reduce the 800 to 900 that you have
Yes.
to deal with.
Once it goes through our deferral denial process, I don't know what the 5% does with those, so, but yeah, you're right. So once we go back down that list, 35% of that would be smaller than originally thought.
Okay, thank you.
Councilor Watts?
Thank you. But there will have to be medical priority considerations given, right? So it won't be
Yeah.
totally only backlog necessarily first. There's just, you're gonna have to be juggling those priorities.
Difficult, because there's not necessarily an emergent MRI. So we're gonna have to look at each case and see who's been waiting the longest, or what's the biggest need, and somehow prioritize those, so. It'll be difficult.
Thank you.
Anyone else? All right. Thank you for that good report.
Thank you.
Next is our Health Director, Ms. Connie Davis, will give us a report on Cherokee Nation Health Services.
Good afternoon.
Good afternoon.
Thank you for the new accommodations. A little more comfortable. Some highlights from the report that you received. This is in the month of February. Wilma P. Mankiller saw 8,926 patients. Redbird Smith, 8,390. Salina, 7,310. Jay saw 6,252. Nowata, 4,082. Muskogee, 12,081. Bartlesville, 1,679. Veneta, 5,448. Our Gadoogie Clinic, 429, and Hastings, 23,781. I got a report in the by email this afternoon as well, or maybe it was this morning, that our trend continues to go up in patient volumes by 10% every year. And I think one of our biggest growth areas is Veneta. I think I reported last month, it was 105%. And so the new facilities there are having a huge impact on the patients in that area, and I think that's something we could all be proud of. In our emergency department and urgent care, they saw just over 5,000 patients during the month of February. The left without being seen rate was 4.5% in the emergency room, and our goal is 3%. So that's a huge improvement, and I think next month's report, I'm going to blow it a little bit early, but we've hit 3% finally. So we'll do some crowing next month. But the urgent care was still at 7%, and we're working those issues out as well. We performed 323 surgical cases in the month of February. Behavioral health saw 1,082 patients. The Jack Brown Center has 20 patients right now, 12 males and 8 females, and there's still 12 on the waiting list. And I'm hoping in the next few weeks we're going to be able to open up that new center, and we have 36 beds there. So right away that will tell you those 12 will no longer be on a waiting list. It'll be a great service. And another thing, as promised, that we would follow up on the 90-day impact. We have about 13,000 prescriptions being filled on a 90-day supply, and thank God, so far, we have had little to no significant impact on our collections. So we were concerned that we would have a big financial impact, and there has been some, but not to the point we were worried that it may be. So that's working well so far. The Cherokee Elder Care, or PACE program, has 130 participants. That group is staying busy, and Dr. Stephen Younger has resigned his position there, and we're actively interviewing and recruiting to fill the medical director position there. The PACE and the Cherokee Nation Home Health also received their survey from CMS, and they had some findings, but they all have corrective actions put in place and will continue operation. The home health said that was the first survey they'd had in over 10 years. So there were things that, needed to be updated a little bit. We celebrated Doctor's Day on March 30th, and I spent a few days in that week and the following week handing out gifts to our providers, and they were appreciative of it. I've received several emails. So think about it. The docs in your area, you might call and thank them for their service to our patient. And Dr. Montgomery, I'm going to ask him again to come up and do a presentation on Palladian, the people helping us manage our back pain patients, because I know you're receiving some calls, we're receiving calls, and just to clarify how this works and why we're doing it. So, Dr. Montgomery, if you don't mind.
I had one question on that 90-day before.
Okay,
you-
okay, right ahead.
If it's okay, yeah. The 90 days, so there's no financial impact on how many active prescriptions?
13,000.
Actually, Colleen, I can that's when I came to the office early this morning for.
Come right up and update us, because I want to know how many prescriptions we fill in all, not counting the,
My fault she didn't have real current information because I didn't get it updated till today.
Well, but this is February's report too,
Oh,
so.
okay, oh, okay, well, this is March's report, I'm sorry.
well, we want to hear from
Yeah,
you.
through March, we're at 14,601. So we've had a pretty good increase, I think, in what we've seen. For the month of March, that was another 2,008 90-day supply prescriptions. And as far as the financial impact, and I'll base this on what we purchased in medications versus what we collected for the month of March. February is included as well. I'll just give you both. Did you have that in there too? The numbers, okay. In February, we spent $1.4 million on prescriptions, and we collected or were authorized for payment. I'll put it in that language because sometimes we don't get the full amount from the insurance companies either.
but we were authorized for payment for $1.5 million in collection. So we were actually about 6% above what we spent on drugs. Then in March, we saw a decrease. We spent $1.67 million in prescriptions for medication, and we collected $1.579 million. So it was about 98%, which so far has still been pretty good. I think that's great. As time progresses, once again, we'll see more numbers and we'll have more information. But so far, the program rolled out. I think it's been quite successful, and patients seem to be happy as well.
Okay, if we had 14,600 and whatever going to the 90-day prescriptions, how many patients remain at the 30-day supply? How many thousand?
Honestly, can't answer that up front. I have to do a little more number crunching to get that for you. As a representation, I would say, let's just take it as a percentage of total prescriptions filled.
Okay.
We're probably looking at around, right now, 2% in our system have converted to 90 days.
So our pharmacies are generating a lot of prescriptions being filled, thousands and thousands. This is just, the 14,000, like you said, was like 2%, so. So evidently, there are a lot of people out there that are perfectly satisfied with 30 days.
And that is exactly how I view the program right now. I think they're very happy receiving their prescriptions timely in the mail and have no issues with what we're doing. Now, there are those that it certainly benefits, and I think those represent maybe the 14,000 that we see here. And I anticipate we'll see more. This is still kind of new into the program as well. But once again, it's completely available to them, and I think it's so far it's working well.
Okay. Councilor Lay, did you have another question? Thank you. That's a good report. Okay, Dr. Montgomery, let's hear about Palladium.
I'll just start by making a few opening comments. I hope that's okay. Coming from the standpoint of a person who's now in an administrative role, but also someone who treats patients. In the last several weeks, I've actually been helping out in the clinics. I try to see patients on a regular basis, and I see patients with back pain. I've made referrals for some of those patients to what I call the outside consultants called Palladium. So I have intimate knowledge, daily, weekly interaction with patients that experience back pain and need treatment for back pain. Treating any medical condition combines both science and art. The development of new tests and new medicines is the science of medicine. The art is the application of the science to individual patients. When a provider's understanding of the science may not be quite up to date, or the application of that science is not rigorously applied, variations in treatment and variations in outcomes occur. This is true for the treatment of diabetes, and it's true for the treatment of back pain. You can take 5 providers, give them the same patient. That patient can be a diabetic. Those 5 providers might use 5 different medications, and the time that it takes for that diabetic patient to achieve a therapeutic or good glucose level will differ among those 5 providers. And there will always be one provider who probably does it just a little bit better than the other 4. That's the reality of medicine. But we hope through science and training and education to get those 5 providers to the same place and achieve the same goal with an acceptable time frame in treating diabetes. The same is true for back pain. It's a complicated problem, and the complexity involves diagnosing the cause and prescribing or recommending the right treatment. Cherokee Nation relies on help from providers outside of our system to diagnose and treat back pain. And different providers that specialize in the treatment of back pain recommend different procedures and different treatments that lead to different outcomes. This was taking place before I came on board a couple of years ago. So when this administration came into place, we felt that an outside consultant could help our providers diagnose and treat back pain. And advice from this outside consultant would hopefully lead to better outcomes for our patients with acute and chronic back pain. Cherokee Nation Contract Health Services, under recommendation from Blue Cross Blue Shield, contracted with the entity called Palladium Health of Buffalo, New York. he might call to him, again, an outside consultant, a person with no vested interest in doing anything other than providing good advice on how to diagnose and treat back pain. Palladium uses a team of providers, specialists, neurosurgeons, orthopedists, neurologists, specialists in physical medicine, rehabilitation medicine, and chiropractors and physical therapists to ensure that the referrals for spinal care meet what is called evidence-based guidelines, the science of medicine, hoping for the best treatment and the best outcome in patients with acute and chronic back pain. To date, Palladium has helped us with numerous cases where patients were receiving various forms of treatment, including repeated injections or possibly surgery, that was reviewed, analyzed, and determined as being necessary, and in some cases, unnecessary, based on evidence-based guidelines. No referral, MRI, injection, or surgery has been denied that met medical necessity by review from these outside providers with specialty training in treatment of back pain. Those are the opening comments I would like to make, and then I'd like to answer any questions that you might have. Do you have anything to add, Ms. Davis?
I've got a comment and Counselor Lay's got a question. I think the problem is probably that we're just now getting this information, because several months ago I had a teacher call me, and a coach, and she was just panicking because she was going for her injection in her neck or whatever it was. And when she got up there, this provider told her that about Palladium, and she didn't know about it, so she said she didn't, and I didn't know about it, and I kind of had the same idea that Counselor Lay had, and then I got educated about it, but it was kind of Johnny-come-lately before we found out what was going on, and I'm kind of bad to jump to conclusions, and she was telling me, you know, it's just another hoop that we got to go through, and I can't get my whatever kind, I don't know if she needed epidural or whatever it was she needed. I'm not a medical person, and I didn't know a thing about it. I found out about it just a hodgepodge here and there, and I called several people, Redbird Smith here and there, who is Palladium, what do they do, and kind of was on the end of it, you know, not up front with, I didn't feel very knowledgeable, but since then I have researched it, and I know what you're saying is true, and I understand it, and I agree with it, but my point is, we found out about it through a bad way, is the way I found out about it, was a problem. Like, she called me, and it was time for her appointment, and she didn't know how it was going to be paid for, and she was in pain, and it was just, didn't go smoothly at all. But it finally got it worked out. But that's my comment about it. So, Councilor Lay?
And thank you, and I had some of the same concern. How much are we paying these folks? On an annual basis, or per patient, or what?
Paid per referral.
Per referral. And how much is that?
Depends on the referral. If it's a simple referral, it's $15 per referral. It's $25 for a more complicated referral.
How much will that be, do you estimate, in an annual basis?
Can't answer that. Depends on the number of referrals that are made.
Can't answer, you don't have a rough guesstimate of what we're going to pay?
To come up with a guesstimate, I'd like some time to look at the numbers and bring it back to you.
Well, and we started getting phone calls, probably a lot of us did. And at first, I thought they were being denied out of Claremore, so I kept kind of chasing my tail a little bit until I found out, I guess we were denying them. Then I found out, no, it's a company called Palladium.
That's the same way.
And I knew nothing about it. And our patients know nothing about it. We did, I guess, a bad job of education for the counselors and the patients, probably more important, the patients. And so I'm calling the clinics and saying, what's going on? They say, yeah, they're denying everybody. I don't know if that's true. That's probably not true, but they're denying a lot of people. And so when I get a call and I call you, and you folks start defending yourself immediately that this is the way that we're going to do business, and I'm saying, well, okay, what about this patient who now has pain, who's been denied that injection or that pain operation or the pain injection? Do you just let them sit out there and suffer? I mean, that's That's what I'm asking you, because about once every couple of years, I go in for my knees to be injected. And that's going to be a continual thing from time to time until I have them repaired, probably. That's what I've been told by Tulsa Bone and Joint, and I think they know as much about it as about anybody. And so if I get denied, if I do something wrong and I overreach, overstretch, whatever, and I get denied and I have this pain, what do I do then? I'm just denied. You gave them no option, which is what upsets me. And I hope that you can understand why I became upset, because I just kept getting the phone calls, one after another, figuring it was Claremore's problem. It's not, it's our problem. Thank you.
Well, I think, this is my 2 cents worth, that the better educate our constituents, patients that come in, they may not totally understand it, because like I say, when the lady called me, I had no idea on earth who Palladium was. I thought, we don't work that way. I don't know what this is. And that's how I found out about it, by asking all these different people. And I'm sure there are maybe rare instances where people, you know, can get addicted to different pain things, and they want it right when they want it, and they might have been used to getting it that way. But I think it's a good idea to have a medical review board, more or less, to go through this, to sort out by these experts. And their fee didn't seem that much to me, but when people are expecting to go for an appointment and they find out at the last minute there's something called Palladium that denied them, that was the problem that I had with it, is the way this all took place. But maybe it's working out smoother. I hope so.
I've got one more, if I
Yes.
could. The alternative, what's the alternatives? I mean, to me, I looked at the Palladium bios in their makeup of their management. I see a lot of chiropractors. Chiropractors are good in their place. They think they can heal everything by manipulating my back, my spine. I'm not sure that's correct. So what's the alternative? What are we going to do for these folks? Just say, you're denied, go home, have the pain.
We'll
That
continue
seems
to
to be what
perform
we've done
the
here.
same procedures. The challenge we're encountering, Councilman Lay, is those providers are not documenting medical necessity, and that's what we've identified as a problem. It's a waste of our funds, and in visiting with the patients, they may go get an injection and say, we asked them, did it work? Well, yeah, maybe for an hour or two, but then they go back in 3 or 4 months, and the providers that we've referred to do the same procedure again, and we're having a challenge with some of those, and it's helped us identify some of those bad habits, if you will. Because we don't want them doing unnecessary things to our patients. I think you would all agree on that.
Well, and if I may, I think our doctors are sending them out, referring them out, and these folks that are doing these injections, at least the one I use about once every couple of years, is top of the line. And I don't think he's going to do something to me that he should not. I don't get where we're going. Am I going to say I'm not going to trust Dr. Montgomery? Everybody's going to laugh me out of this building, okay? See what that's where I'm going here.
I kind of came prepared for that. Here's a referral for one, same patient, 2 different neurosurgeons, 2 highly qualified. I don't want to hold these up to, I don't want to violate patient confidentiality, but this one recommended surgery, this one recommended physical therapy. Differences in opinion occur with every medical diagnosis there is. And sometimes recommendations are widely different.
And that same here.
This is the same patient.
Yeah. A close family member of mine just went through some of this. The very conservative ways of going about treating were all done first, and I think I've probably spoken to several of you about it before it went further. We went through that for close to a year. All of the conservative ways to do it that you're referring to, that physical therapy, we went through all that. Didn't work. Not saying it's not gonna work all the time, but it didn't work. It ended up in a surgery. And so I'm very hesitant to say this, but, you know, we got somebody in New York City telling our patients what to do in Oklahoma in the 14 counties. It's kind of like that TV commercial, the salsa from New York City, you know, get a rope.
Councilor Lay, these are two neurosurgeons from Tulsa.
I understand that.
Two different opinions.
One of them's conservative.
Right.
One of them went to the surgery. Now, did the one on the surgery already go through the physical therapy? I don't know.
They have not. Point there being that sometimes I would always advocate a conservative approach with acute back pain that's supported by the science, Councilor Lay, not by.
Okay. Well,
And also, I don't have the numbers, but you know, one of the more challenging problems we have with Cherokee Nation patients is what's called failed back syndrome. Patients who have surgery, they don't get better. For a variety of reasons. I'm not implicating that every surgery that didn't turn out well wasn't indicated at the time. But there are a lot of patients out there that have had surgery that don't get better. So I would always advocate a more conservative, cautious approach before having surgery.
and I understand that, but here again, we're talking I think the calls that I started getting were the injections.
And likewise, I have to say with injections, it is not a benign treatment.
Well, I understand that, but what alternative are we gonna give them? That's my point.
And my reply to you is that the responsibility for someone with chronic back pain who's getting epidural steroid injection, the responsibility falls on, in part, on the provider who's providing the injections to document and provide Palladium the evidence that what they're doing is a benefit. If they give the information to Palladium that says these shots are working, they will not be denied. But if that provider isn't willing to more or less play ball, and I hate to simplify it that way, but at least help to some degree by providing information back to Palladium that shows that what they're doing is helping and not hurting the patient,
So
then they won't be denied.
So we're in a paperwork shuffle?
Exchange of information is what I call it, yeah.
Okay.
Documentation of benefit.
So if they didn't fill out the paperwork and send it to Palladium, they got denied, and the patient didn't even know they were gonna get denied until they show up.
That happens, then again, the patient can appeal to contract health, and that will then go to Palladium, and they have people in place who will then provide the information as to why it was denied if it was just a matter of paperwork. But sometimes it's even misinformation that's not provided. But again, Councilor Lay, I go through this all the time. If I want to do an x-ray, I have to give a specific, accurate diagnosis why I'm ordering that x-ray. I have to say whether it's the left leg or the right leg. Providers know this. This isn't a hurdle that we don't deal with every day, that most providers should be willing to do.
Is it electronic, or is it?
It is, yes.
Okay. And so, well, EHR is something else I'll talk about later. But they fill this out electronically. They send it to who, you or Palladium, or?
It's too Palladium.
So they're not doing that, is what you're saying? That's why they got denied?
Some of the denials, again, if they submit information that shows that it's really not being of much benefit, then it may be denied for that reason. It's not working. You shouldn't be doing it.
But the patient, here's what I'm getting at, the patient themselves show up for these treatments, whatever they may be.
Right.
They don't know that they got denied. Is that correct or not? That's what they're telling me on the phone.
Well, I see your point, and I'm going to say I'd like to get specific scenarios and come back with you and see what the process is. I don't want any patient to show up, find out once they get there that they've been denied. That shouldn't happen.
Okay.
I agree.
Thank you.
Well, I gotta put my 2 cents worth back in here again. That is what happened to this person that called me. It was time for her appointment and she'd been denied. But in defense of what Dr. Montgomery is saying, it was the doctor's office in Tulsa that had wrongly identified where she was gonna have her epidural, and it was a neck injury, and they had said it was something spinal, 3 vertebrae down or something. They were in the wrong, her doctor's office that she was going to. But I guess I've had so many friends, neighbors, and family that have had what you would call the failed back surgery. It did not work. And I'm not a doctor, I'm not a medical person, I'm just a layperson. But what I have read about the American Board of Surgeons, read a lot about this, say that a lot of the back surgery is not successful, and they are recommending chiropractic before, as you go to the last resort. And I think we're taking a step in the right direction. We just need to educate everybody about what we're doing. I hate to be the chair of the health committee and somebody call me up and start asking me all this, and I don't know straight up from sick'em about what they're saying, because I never heard of Palladium. I don't know what you're talking about. But now I do, but it would have been better off if I'd known in the beginning. But I don't know how we're supposed to find out these things, except just maybe that's what we're here for today, so we can all work together better. But go on, Dr. Montgomery.
Say, we're working very hard to correct any problems that occur. Palladium has a person dedicated to answering these concerns that come from our patients, and our providers are in constant, regular contact via email with this person to try to remedy the problems that come up.
Okay, we've got some questions here. Counselor Keener.
Thank you, Madam Chair. Thank you, Dr. Gutman. I too experienced some of these phone calls or emails. And I guess, so for the patient who is in pain today, and they go to one of the clinics, let's say, and they have been getting treatment all along, is there kind of a shift here that they're not used to as far as it goes to Palladium with their treatment? So they may be getting one source of treatment, one course of treatment, I should say, and then it changes all of a sudden with Palladium? And that's what...
I would argue that if a provider provides the accurate reasons for why a patient is getting a specific ongoing treatment that is beneficial, they'll continue to receive that treatment. Palladium's not going to interrupt that. But it's important to provide the information that documents the benefit.
And I agree with you, because treatment without diagnosis is malpractice. Would you agree with that?
Treatment without benefit.
Right. So, but what I think I've heard from some of the people is that they were on a course of treatment, and then they were either denied or something, or the treatment changed, and they maybe did or did not agree with it. So, and that's neither here nor there with me, but that's between them and their provider. So, but let's say they are denied, so what's the recourse? And they're still in pain, remember.
In the end, the ultimate, the primary relationship between the patient and their primary care provider should be the fallback place where they discuss any decision made about their treatment. They should feel like they can go back to that primary care provider and say, I thought, I wanted this treatment, I thought it was beneficial, but for some reason it's been suggested to be changed. They should be able to discuss that with their primary care provider.
And what's the time elapsed there for when they know? Is it right then at the office visit?
I think most referrals that are done to Palladium, there's a decision made within 48 to 72 hours, I believe. Yeah, it's not a lengthy delay.
Okay.
Provided all the accurate information is there. And our providers, by the way, Palladium's made a very genuine effort to educate the providers and let them know about what's needed to fulfill, complete these referrals and the referral process. And I won't deny that we've had some problems there too. It's like any new process in a computer. It's not always easy. It's not always easy.
So Palladium has educated the providers educating the patients in the same manner?
I'm not sure I know how to answer that. So again, the decision by Palladium should be conveyed to the patient by a provider. Why something was approved or not approved. That should be conveyed to the patient by the provider.
I think that might be a little bit amiss right now while we're making this transition.
I think that some decisions are getting conveyed without the provider being involved. Yes.
Well, at least you can work on that fairly easily.
Yes.
Thank you.
Counselor
Madam Chair.
Vargas, you're next.
I was just gonna say that I had probably 3 or 4 calls where the patient had shown up and was denied, found out they were denied. But I had talked to Brett and to Connie, I believe, and it was a lack of communication between the doctor and the lady, and it was quickly resolved, and I just want to say I appreciate that.
Counselor Watts?
Thank you, Madam Chair. On Palladium, I am excited about it. I remember when you originally reported on it in committee, that I thought it was a really good opportunity. I guess because the emergency room at Claremore, sometimes I have had to deal with what I guess would be determined as drug-seeking situations. And that obviously doesn't just affect that individual, but affects that whole family and our system. And that means more than likely somebody's in pain still, or had been, and we could have avoided it if we had had a case management to actually solve their back issues or other things. And that's the way I understood Palladium was. So my concerns with it are that when I asked for, because there was beginning of what I guess are a round of phone calls for folks, I asked for a patient like handout or something on what this looked like. We really didn't have a flow chart or anything. So I do believe in putting that in front of the patients so they know what the program looks like, what the process expectations are, a point of contact directly in your department maybe, and just get those expectations out so they know what their patient rights and obligations are in participating in the system, what that looks like. So I don't think we have that, and if we do, I know I need it because I'm getting those calls as well. And then whatever is happening in the system, I see a couple of communication problems. First of all, it looks like at the patient level, they're not being told that some are not, that we're transferring to this new system. So I've gotten phone calls on folks that were in the old system, had already gotten referrals, those have been scheduled, and then suddenly Palladium's on top of it, there was a switch and there was no communication, and they were caught in the middle of trying to get to Tulsa or wherever that was, and things had failed. But I also had similar phone calls, and I've sent them all on to you, I think, and Brett.
Well, I've received some.
So, how are we resolving that? Because some of the feedback was it was our partners may have been dropping the ball on these appointments. A lot of the folks that I'm talking to, either resources that they just don't have the gas money, so if one failed trip means they couldn't make a second failed trip, or they just only have so many people that are in so much pain they can't drive themselves, and those resources are limited, and we're potentially wasting them to get them to and from. So how do we move forward, I guess? I don't know that I've heard that. And it's not that, I know you're proactive, so I just want to know so I can explain to my constituents how we're going to move forward with it.
Well, I think the recommendation of a brochure to say, what happens next with all of our back pain patients is something that we can ask Brett and Dr. Montgomery to work on to help give all the patients. I think that's very important. And as you identify problems, like I said, we rolled this out in July. There are going to be things come up that we don't know. The better you guys communicate with us, specifics with the individuals. I know Counselor Lay sent some to me. Counselor Fishing Hawk, there's several in the room I've heard from, has sent those to us. So as you identify those, we don't want anyone to hurt. This is not to avoid treating people for pain. This is to get them the best service that there is. And we want to resolve those. So just communicate those things to us as quickly as you can, and we will address them individually. Sure.
Counselor Walkenstick?
Hey, Connie, first I want to tell you, appreciate you guys assisting me a while ago. I feel a lot better, by the way. What's the, did we get any positive feedback on the joint venture with the IHS from Congress? Have you heard anything?
We don't really have an update right now on that. We have meetings, I believe, next week, and maybe that will give us some good news.
Yeah, I was reading an article. Chief Baker went down to Washington last week and spoke from Congress and lobbying, I guess, to restart the joint venture. I mean, has it kind of fell off, I guess? And
I don't think you'd ever say it's completely fallen off, because we have some strong support in Washington on those issues.
Thank you, Chair.
We got any more questions about Palladium? Councilman Garvin?
Yes, thank you, Madam Chair. As I see the problem, looks like it's communication between the provider and the Palladium. No one likes to be people looking over their shoulder, especially when they're working on somebody's back. And I got a feeling these providers are not communicating with Palladium because of their, they got this little diploma that says they're the best, and they don't want to be money-burning quarterback from someone. And I don't think you'll ever change that, but that seems to be the problem today. They just don't want to admit what they're doing is not right. Not I'm perfect and I do everything right. But I don't know the solution, but I see that as a problem. And I don't know how we're connected, Blue Cross and Blue Shield and Palladium, how long it's been going on or how long it's going to continue. But I suppose there's other choices besides Palladium if they don't do the job.
Well, there's really no direct connection with Blue Cross. They just, I think, in working through our contract health department, knew that we had issues. You know, we know where we're spending a lot of money. We know where we're spending a lot of money on services, and we were able to identify a service that had wide variation in outcomes. We asked them, do you have any ideas about a possible solution? And they mentioned to us about this. And yes, but there's no direct financial or contractual agreement between Palladium and Blue Cross and I want to make that clear. Your other point is, you're right. I think providers are, it's difficult for them to have someone, as you said, look over their shoulder. But I will say that some of the groups we have no problem with. They do a good job of providing the information. They communicate readily by email with Palladium. They communicate readily with our contract health department. Others, for probably the reasons you say, I'm not going to say for sure, but for the reasons you say, are less willing to provide that information.
I believe at last look, we broke down how we were spending our contract health funds. I want to say that there was around $5 million in orthopedics. It's not just broken bones or your knee replacement. That would include the back pain services. And so if we can manage that better, or if we're spending it unwisely on things that aren't medically necessary for our patients, then we want to correct that because we want the best for our patients. You know, and it may be a change, and change is hard. I've been a nurse for 25 years, and some of the things we used to do that were acceptable practice 20 years ago are no longer acceptable, and it'd be hard to go back to the bedside. I could do it, but I'm gonna have to relearn some things. And that's what we find a lot of times when you bring the updated evidence-based practice.
Change is hard, I agree, but also change is good. So we gotta look at the right side. Thank you, Madam Chair.
Well, thank you, Dr. Montgomery. It was very enlightening. We all learned, and hope it trickles all down. And I think Councilor Watts' idea of a brochure is excellent. If we could hand somebody a little pamphlet that says, what is Palladium, and then kind of explain what we're doing. It's, on anything we do, it's hard to get it down to the people who really need it, because I have people every day, they'll call about scholarships, and we have tried to saturate education department about, and then never heard of the Cherokee Nation Scholarship. So even if we're trying the hardest, it's still hard to get all the information out there. But I do think that would be a good idea to have a brochure.
We can do that.
Thank you, Dr. Montgomery.
But if you don't mind, I'd like, while Dr. Montgomery is up here, to share something that he experienced this past week. I mentioned a couple of months ago that Cherokee Nation Health Services was recognized by the American College of Physicians for the Loveland Award, and he attended this last week to receive that in our honor. So, Dr. Montgomery.
I had the honor of representing Cherokee Nation at the American College of Physicians meeting this past week. The American College of Physicians is the second largest physician organization in the United States. It's behind the AMA. We have over 130,000 members. The meeting was attended by over 6,000 members. We were nominated by the governor of the Oklahoma chapter, Dr. James Baker, for this award. Past recipients have included the National Cancer Institute, the American Cancer Association, American Heart Association, the Center for Disease Control. It's also been awarded to individuals, but it's also been awarded to health systems and other entities. And again, it was the Edward R. Loveland Memorial Award for Distinguished Contribution in the health field. And I was there at the meeting to receive the award on behalf of Cherokee Nation. Again, I want to thank you all for the opportunity to represent Cherokee Nation in receiving this award.
Great. Yes. Counselor Garvin?
I might add that Dr. Baker's a good friend of mine, and we kind of work together on this, so.
And I want to acknowledge you for your role, and thank
You
you
did a
also.
great
It's a
job.
tremendous honor.
Thank you for accepting.
Counselor Watts?
Thank you. I had additional questions. I thought we were kind of limited to palladium. It sounds like it's wrapping up though.
No, go ahead.
Okay. So, on your recruits report, will you put whether they're Cherokee or not?
I'm sorry.
On the recruiting report, would you
Oh, for
list
the
whether they're
providers?
Cherokee or not on the providers? And then I really appreciate, it looks like we're addressing a MRSA or infection issue at the facility, because I assume, are we publicly reported on that as well, like you would other hospitals in Tulsa? On
Yes.
what our rate is? You can find that online?
I think it's reported by county.
By hospital, by county, online? I haven't,
I'll have to clarify.
okay. And then, the pending follow-up on CHS on contract health service, we've talked about it for a few months now, but I didn't see it added on how we're reporting out the pendings actually being served.
We discussed that right before this meeting. Mr. Hanson, yeah.
Okay, so it's still on your radar to figure out a way to report that, so we can kind of get an idea of how to, okay. And then, one last thing, I was trying to read the dental report, and I was trying to understand, like the scheduling. The way I read the information statistically about our population is that you're lucky to maybe see them once or twice for a clean, and I'm glad we're doing 2 dental cleanings a year, like you would see in private practice. Was I reading it correctly?
I'm not sure where you're going, but yes, we're trying to.
Working on getting that system. Currently, it's up to the patient to call in, and the patient, it's up to you to call in, and any kind of recall system put in place currently, unless you're under recall for an active acute problem that's going on, an ongoing problem.
Okay, but the way so the way I read it was that we're working towards a system you would see like at a private dental
We'll
office,
contact you, yes.
where every 6 months, if you hadn't already set your 6-month dental cleaning, you would be contacted to set that up,
Yes.
which is exciting, so thank you.
Yeah.
So, like, if they're a patient and they have a dental cleaning and they have 2 cavities or more, would we set them up and do 1 cavity each time and have multiple deals, or would you set up 1 appointment after that and take care of everything in that 1 appointment following the 6-month
Depending
cleaning?
on where it's located. I mean, if they're both in a place where you can do it in one appointment, yes, you do 1 appointment. If it's something where they're on one side and the other side, you do 1 on both sides, so obviously we did 2 appointments.
Okay. Thank you very much. I was trying to understand that.
Sometimes when we say where, we think geographically. You
Okay.
saw the location of the mouth, yes.
Very good. Thank you very much, everyone. Thanks, Madam Chair.
Counselor Keener?
Thank you, Madam Chair. I guess I'll start with page 20 of your report.
My pages aren't numbered, so
Oh, it's the year-to-date summary on CIH review. February. Okay, ask you to help me understand the total screen, about 900, and then the non-Cherokee, 300, about 300.
Well, that list comes out new per week, so that's a summation of 4 to 5,
February.
So, there's 1,000 that are denied/deferred. Out of that, in the Claremore system, a significant number of patients are referred that live in South Tulsa or Glenpool or, areas that are in Tulsa County, but not in our area at all. Would not be in Osage County. There's,
Okay.
that's the non Out of area, that's the out of area. There's a significant number that are non-Cherokee. You do the first, if somebody strikes out on one of those, that's it. They might be both, they might be one. Occasionally we see somebody that lives in the area, they're Cherokee, but they're not in the database. They only have a CW first, they're not a citizen. So that's it. That's the issue.
Would that include other federally recognized tribes? Or
Non-Cherokee is it's all, they're all eligible, because they've gone through the Cherokee Nation, unless it's a pregnant spouse.
Okay.
But otherwise, they're Indian descendants.
Okay, thank you, that makes sense. I was going to ask you about the healthcare info system, the new one. Have we already purchased that?
The electronic health record, we're in the process, yes.
And refresh my memory, that's been approved by council, that expenditure?
It was in the budget
Yeah,
for
I
the
vaguely
last 2
remember
years,
that.
I believe. There were funds for that.
And that was, do you remember the cost on that? I think it was, you told us it was 13 million.
We can't discuss it publicly. We have a non-disclosure, so after the meeting,
Okay,
we have confidentiality agreements signed.
okay. And then I think about 2 months ago, Dr. Graham was here, and he was working on the contract support issue with CHS. So is that getting anywhere closer? Or, I think he said he promised, or he may not promise, but he said it'd probably be solved in a month or two at that point.
The contract support issue, I know they're meeting again in Washington next week to discuss that further, so I don't know.
It's moving forward, maybe.
We hope.
And then also on that Oshaleta that we broke ground for, when's the opening for that? Remember?
We're hoping December, January.
And then once it is opened, we're working on the joint venture. Is that going to be for equipment? Or that just for building?
That will be the joint venture would be for operational expenses.
Okay, that's good. So that's how we're going to pay for that.
Well, we don't know.
We don't know, but
yeah.
but let's say we don't get that, what's going to happen then?
Well, we're gonna have to look for our budget. We'll have to budget it in to our big budget coming up for this next year.
And that's probably 5 to 6 million, based on what NOWAD is doing, kind of, if you want to compare those two?
For the whole, I don't know
Operation.
specifically for Oshaleta. I think we're gonna be looking for about $9 million for equipment purchases for all the clinics.
And that's it? Oh, okay.
No, I don't remember the breakdown per clinic right now.
Okay. So, but if you take NOWAD, which is similar in size, not exactly apples to apples, but that's 5 to 6 million. So for operations, that's not including.
I'm just talking purely equipment right now.
Okay, so the 9 million you said for equipment will be spread over all.
All the clinics that we've explained.
Okay, and that's equipment only, that's not operation.
Right.
So that'll be a big chunk out of the budget then. We do not get that, so we do need to get that. So,
We need to make sure third-party collections keep going as promised, and we're hoping maybe some of the carryover will fill that.
and time is getting close on that, isn't it?
We sent out the budget planning this week, so our staff will start working on it probably this week and work with the treasurer's office and then have a presentation to you guys, usually in August, I believe.
You're going to base that off of not getting any monies? Or have two scenarios?
We'll probably have to have a plan A, a plan B, and a plan C. Just to see. When you have growth of 10%, that means everything goes up. Your contract health, you know a percentage of every patient you see is going to generate more contract health expense, just by the nature of the business. So.
And I'm glad you said that, because that is the growth area. So what did we say last month in Claremont Hospital? It was 5 patients, 10 patients, or staying at the hospital? Something like-
I've heard it was less than that.
3, I can't remember.
Something like
Hastings is 11,
The average daily census at Hastings, I believe, is 19.
19, okay. So we can see where the growth area is. Okay. Thank you, Connie. Thank you, Madam
Speaker
Chair.
Jordan.
If everyone's had an opportunity to talk, we may want to move on because we're an hour out.
I have, the only thing I had left was I wanted Mr. Hale to share some very exciting news on our Press Ganey patient satisfaction surveys. And then we had our annual DNV accreditation survey just this last week. And I asked the staff to video the survey comments. And I thought it would just be more of an impact if you guys heard directly from the surveyors their opinion of our health system. So those are the only two items I have to complete my report.
Counselor Buzzard.
Just a couple of things. Real quick, Connie, on the Affordable Care Act. Last time we met last month, I think we had 9 that actually signed up on the Affordable Care. And I don't know if you're tracking that or not, but it concerns me that we don't have more people signing up. And I think maybe the problem is we're not getting it out to our patients. And I'm familiar with Sam Howard. I know that people that know about the Affordable Care Act are not going out and telling the patients about it. And I think that's the only way you're going to get the word out. It's to give them the benefits of signing up on it. A person that is 1 to 200, 300% under the eligibility, doesn't have to pay anything for it. And that's a good thing. If they qualify for that, then they can go automatically to any provider they want to get services. I don't know that's being conveyed to our patients because a lot of our patients are going to be 100% to 200% under the percentage of qualifying. So I just feel like we need to get more educational opportunities out for them. I've been to a community meeting before and I saw the patients, I saw the people there that was going to be telling about it. They had a booth set up, which is fine, but they didn't have any presentation at all. And people are not going to go up and start asking questions about it. I think we need to give that information out to them. So what I would like to see is to go out into the patient area at our clinic and give that information out and explain the benefits of having it and signing up, because what I'm hearing now is everybody's asking for exemptions. Everybody wants an exemption. I think the last meeting we had here, like there was 9 that signed up, and I'm glad the 9 signed up, but I've also heard the story of a person signed up and a man and woman had to pay a penny a month for their insurance. Anyway, I just wish we could get more people signed up because it could benefit us.
We do too.
As much as the patients.
And we've trained, again, 32 people throughout our health systems. There's somebody represented in each clinic on how to sign patients up. That number of enrollees is up to 40 by last report, but still, when you're looking at 1 million visits or 300,000 patients, that's still not as many as we'd like.
And I just don't think the patients, the 32 that we've trained, and maybe they are in other clinics, I don't think they're really giving the information out to the patients there. They're waiting on those patients to go back to their office, and they're not going to do that.
Well, we can certainly ask them to be more proactive in disseminating
The other
information.
thing that I had real quick is last month we talked about mental health issues. I think you were in the process of evaluating that particular program to see where you are on it. We're still looking to see if we get more providers in that particular area.
We have spent a lot of time with our behavioral health department in the last several months, and particularly the last couple of weeks. So we hope to give you an updated plan in the next couple of months.
The other thing I want to comment on is your third-party collection that has really increased. And I know we talked about that for the last several months. I've been on the council, and I can see a big increase in those things. So somebody doing a good job.
We're trying. Thank you very much.
Thank you, Madam Chair.
We really do need to move along here. We got a late start because one of the counselors had a little emergency, medical emergency, and but it all worked out. And Counselor Watts, if you got one last question here before
Thank
we
you.
try to wrap it up.
In lieu of questions, if next month, or actually beforehand via email, the 10% trend and the other stuff and the hospitalization numbers for like Hastings, what is our consumption rate for our existing facilities in terms of patients, and then how does that expand to our facilities? And then where are we at financially? So that's one report I'm asking for. And then the other report I'm asking for is the finances side on new facilities, new services, equipment, and staffing, because I thought this was all gonna be paid for through C&B. So now I'm hearing something different. So if you could bring back a complete picture on how it's all coming together, I think I need to hear that or see that, because I'm now confused where we're at financially on it. Okay, thank you. Thank you, Madam Chair.
Councilor
This is just a comment on behavioral health. I think our statistics and in our area here, we're not doing too well in facilities as far as behavioral health in Oklahoma, and probably even worse here in Cherokee Country. We just got back from the Intertribal. Creek Nation is really a pretty good model for us to look at on what they're doing in behavioral health. They may be the leaders in the state. They probably are of all the tribes. Creek Nation is. So it's something that we need to take a look at. There is a need, but we're not ranked very good as far as providing facilities and staffing for that area.
We'll certainly look at it. We are looking at it.
Okay, thank you very much.
Okay. Connie, did you have something you wanted Brian Hale to?
Yes, if we have time.
Okay, so what we're going to talk about here today is just a kind of a quick overview of some of the improvements that we made at Hastings. And I guess the first thing to kind of talk about is what the biggest threat to healthcare is, not just at Hastings, but across the country, and that's spending, and what the government is going to do to everyone to try to get that back in line. And so, you know, America spends basically more per capita than anyone else in the world, and by most accounts, we get less quality than most places in the world. So the answer is more transparency, and the answer is really, from the federal government, kind of a Hunger Games approach to paying for health care, okay? So they're going to use value-based purchasing, and they're going to pay the hospitals that do really well a little bit more, and the way they'll pay for that is by taking it away from the hospitals that don't do as well. And so they're going to do that with value-based purchasing, and one of the components of value-based purchasing is the Hospital Consumer Assessment of Healthcare Providers and Systems. It's a national standardized survey tool. It consists of 27 questions. It was developed by CMS as well as the Agency for Healthcare Research and Quality. And so here's the thing, you can't hide from HCAHPS. The scores are published on the internet, Hospital Compare website, and they're published 4 times a year. It's a top box format. And so what that means is the only answer that matters is always. So they'll say never, seldom, sometimes, or always. Always is the only answer that matters because it's a top box format. So it's first or last. The website reports the percentage of patients who responded in the most positive manner to each question. So the example would be the hospital staff always described possible side effects in an understandable way. And so what I want to tell you all today is 3 things, okay? Why HCAHPS matters to you, what it is, and what we're doing about it. So why does it matter to you as a council member? Why should it matter to you as a patient? We want to raise the HCAHPS scores, and many other problems are going to solve themselves because it's going to focus on readmissions, and it's also going to focus on hospital-acquired infections. And in both of these problems, readmissions and hospital-acquired infections are really costly, both in terms of quality of life as well as expense to the healthcare system. And the other thing is, both of these things are actually really easily avoidable in a lot of circumstances. So what makes HCAHPS relevant? Well, for the first time, you have an apples-to-apples comparison because all hospitals are answering the same 27 questions. It levels the playing field with really strict guidelines for how these surveys are administered. And the results are tied to quality and clinical outcomes. The survey zeroes in on issues that impact core clinical quality, such as pain management, medication instructions, as well as discharge instructions. And it gives consumers, or you all, if you want to look at it, an easy way to compare hospitals. And as you'll see as we go through some of these charts, it compares you at a lot of different levels. On most of these, I've compared this to our American Hospital Association Region 7, which is all the hospitals in Oklahoma, Arkansas, Texas, and Louisiana. And so the reason HCAHPS is kind of important to a lot of hospitals is because pay for performance is coming. So the government starts with pay to report, okay? So they'll give hospitals a little bump in their Medicaid for just participating. But that's kind of the prelude to we're going to pay you based on how well you perform. So in 2007, they started with pay to report. And then the Patient Protection and Affordable Care Act established value-based purchasing, which transitions into pay for performance. Also along with this, CMS is imposing penalties for excess readmissions, targeting pneumonia, congestive heart failure, as well as patients with heart attack. Because those are three areas that CMS says we readmit too many patients. And so when we talk about medications, understanding your medications, as well as discharge instructions, that's how readmissions can be avoided. So, and also council members don't really care about Hastings if you think, well, my patients, my constituents don't go to Hastings, all I've got is a health center. Well, take heart, because we're actually going to be talking about CG cap soon, because the government is going to be mandating that, and that'll affect all outpatient providers as well. So they'll be instituting this for basically anyone who has a clinic as well. So how are we focusing on quality of care? Well, we're using Hardwiring Excellence as our platform for this, and it's from the Quint Studer Group, and it's kind of a nationally recognized platform that a lot of hospitals utilize, and it uses 5 pillars so that we have an organized strategy for attacking these problems. It focuses on people, service, growth, finance, and quality. And the goal of everything that we're doing is not to get high scores. The goal is to have quality care, and then the scores will follow. So, give you a quick overview of some of our efforts to improve the care and the service. And the first thing that we did is we started working on revising and improving the new employee orientation. One of the things that we did is we started including Cherokee culture as part of the orientation process. We also revised and improved the patient safety program. We've hired a patient safety officer who focuses on patient safety as well as patient engagement. We've also improved our documentation, tracking, and reporting of those kind of safety events. We've renewed our focus on customer service. We've provided mandatory formal training in STAR service from the Cherokee Nation Entertainments. We've implemented hourly rounding by the nurses as well as rounding by the nurse managers. And I think that's where we've seen some of our biggest strides. We've also enhanced patient engagement. You've heard about some of our patient breakfasts, but we've also implemented a lot of patient surveys to try and get the patients engaged and get their input as well. So at this point, we'll go over some of these. And again, I want to stress that these come from Press Ganey, which is the firm that conducts this survey. We're not even allowed to talk to the patients about what we're going to be asking. This is really strict, the way that this is administered. So this is done with a scientific methodology. So the first one, and one that we're really proud of, is hospital environment. Because as you know, our hospital is a little over 30 years old. So we had to work really hard at this. The blue line is Hastings, okay? So if you look at July 2013, 65% of our patients rated us always, okay? As far as the cleanliness of the hospital and its appearance. So when we started really focusing on it in September 2013, you see an uptick here. And we've gotten up to 75% and so far maintained it into this last quarter. The red line here is the AHA Region 7. And so really this is a function of when you first walk into the hospital, actually when you first pull into the parking lot, it's keeping up the grounds, okay? It's keeping the place clean. So this is environmental services as well as our facilities maintenance guys doing a great job of making the place look nice. We've also focused on, in the rooms, making sure that housekeeping or environmental services is going in there and getting the trash cans emptied a couple of times a shift. Because a lot of people, they can't judge how whether their blood pressure is being managed, but they know if the room looks clean. That's something everyone can make a judgment about. Number one, the next one here is communication with doctors. So we've stressed good communication with our doctors. So if you look at the blue line here, we started again 79%, and you see consistent improvement here, whereas the rest of the region has actually gone down. So we're up to 88% of our patients say we have always good communication with our doctors. So we're really proud of that. Actually, we started off, I would say, not bad at 79% saying always, but we're up to 88%. So if you see one of our hospitals or one of our surgeons, anyone that admits to the hospital, and that's the other thing to bear in mind, This focus is only on inpatients. For that surveys. So 88%. The next one is communication with nurses. And I think this is also representative of some of the hardwiring excellence must-haves, where you do the hourly rounding by the nurse manager, as well as the STAR service training, up to 86% rating always. And what I think is important to remember here is that it's always. That's such an absolute term. These kind of improvements can really be really difficult to achieve and maintain. So we talked a lot about pain today, because that's the number one reason people come to the hospital, is because they're hurting. And they come here to the hospital to make that better. And so if you can make that better, their pain is going to go away and they're going to heal quickly. So there's two components of pain, and we've got this up here. This is the composite score here. And so we're up to 82% of the patients, they feel like their pain has gotten better. And we've done that in coordination with pharmacy, with the hospitalists, and making sure that, you know, when the nurses go in and ask, they kind of have 3 P's that they ask for: pain, potty, and position. Okay, the first thing they ask is, are you hurting? Do you need assistance going to the bathroom? What does that do? That makes sure they don't get up and fall. And then make sure they get help with positioning in the bed so they don't develop bed sores or anything like that. And so this shows the two components here of the question: was your pain well controlled, and did our staff do everything they can to help the pain? And so you see steady improvement here. 77% said the pain was well controlled, 87% said the staff did everything they could to help. Communication about medicine. This goes back to helping with readmissions and avoiding those. 78% said they always got good communication about their medicine. And so we have several performance improvement projects where it's multidisciplinary with med-surg as well as pharmacy and our hospitalists working on communication about medicine, making sure the patients understand the medicine before they go home. And we have a huge advantage here in that we can send the patients home with their medicine. That's one of the huge advantages with IHS and with the Cherokee Nation facility. So this is the composite going back to 2011, and you see these top box scores, and we look at 2011, quite a bit of red on the board. Number 1, rate hospital, 0 to 10. The only answer that gets you on the board is 9 or 10. Recommend the hospital, cleanliness of hospital environment, quietness of hospital environment, and that's a difficult one to get improvement on. Communication with nurses, responsive hospital staff, communication with doctors, hospital environment, pain management, communication about medicines, and discharge information. So you can see now, 2011, 2012, 2013, 2014 now, we're all in the green. So again, it's not important to worry about the scores as much. Scores are good, but what really the thing to focus on here is the quality of care that these scores hopefully reflect. And so you can see we made significant improvements going back to 2011. And if you look at the mean scores going back to April of 2011, 54.5, top box trend now, the mean, now you're up to 66.5. So again, this represents, I think, a significant achievement on the part of the entire hospital staff, because this is really a team effort, all the way from the person who's weed eating the parking lot, making sure that it looks presentable, making sure that the waiting rooms are clean, making sure the trash is emptied, all the way up to the hospitalist who's making sure that the patients understand their medication, along with the pharmacist, as well as the nursing staff who's in there every hour, making sure the patients have everything that they need. So some of the initiatives that we've done to achieve this is focusing on employee innovation and engagement, the thank you notes, the public recognition, trying to harvest the wins, because success breeds success. Revitalizing the Hastings Hotline as a platform to communicate with our employees. We've also instituted barcode medication administration, just added a line of defense for patient safety. But I don't want to stand up here and say that it's all perfect, because it's not. The areas that we feel we need to focus on still are the patient experience, patient access, as far as getting appointments in a timely manner, clinical documentation, centralized scheduling, and then enhancing our ability to reward and recognize employees for good service. So That's all that I have to say, and I'd be happy to answer any questions that you may have.
Yes.
Thank you, Madam Chair. So that N is the number of respondents. So in April 2011, we went from 54 and a half respondents to 66 and a half respondents, which I'm not sure how we have a half. Is that percentage? It says N is number, it doesn't say it's percent.
N is 125. This is the top box score.
So,
So that'd be the mean.
okay, so it's the mean box trends. Okay, let me back up. How did you do the sampling? How did you approach people? Is it a sample? Was everyone given the opportunity to go on? And out of what X amount of whoever had the opportunity, how many did respond?
Press Ganey administers the survey. So they have strict, CMS mandates that there's very strict guidelines for how this is done. It's only adults, and it's only patients that are admitted in patient status. It's not observation patients, it's not outpatients. For HCAPs, there are separate ones for outpatients.
So this would truly be that average 19 inpatient admitted hospital average.
Every one of
for
them is sent the
Hastings.
survey. It's the response rate that varies.
And again, what was the response rate for us?
125, 135, 141, 97. The reason this is low is because it had, well, that's April 14 to June 14, so that hasn't even happened yet.
So
119.
So for these 2014 results we're looking at a significantly smaller population of respondents.
Not here, no, the January 14 to March 14, 63%.
Okay, because I just heard you say, so your N is 13. I mean, it's pretty far away, so I'm trying to read
This is June 14. This chart was generated by Press Ganey. I can't control what it shows. June 14 hasn't happened yet. It's just showing it on there. What I would focus on is January 14 to March 14, which is 119, but they probably haven't even received all the responses yet. for
Okay,
time
that makes more
period.
sense. So you're telling me to get the 2014 results, 119 randomly selected?
They're not randomly selected.
Okay.
They send one to everyone who's admitted.
Okay, so 119 Cherokee or otherwise citizens that were inpatient at the Hastings Hospital, not an urgent care clinic or anything else. I should make sure my mind's clear, so if somebody asks, which they will, then that's how many people responded to get our 2014 results so far.
Correct.
Okay, that's a reasonable population, I assume. I mean, it looks reasonable. Thank you. Thank you, Madam
Thank you,
Chair.
Brian. That good report. Connie, do I understand that you still have the audit? Were you wanting to?
Yes. If you-
Since we're running so far behind, I think you could email us that or maybe give it to us next month.
I'd
because
certainly be happy to do that.
we need to move on. We've got some new business here. Moving on to our new business, we have Councilor Cherokee, Watson, Lee Keener have 14-028. Yes.
Thank you, Madam Chair. So this legislation is asking to do a few things, and one is to put the special quarterly dividend in a more public place through the Health Committee. That amount of money, because I know we've had questions about CHS 5% dividend funding, and how much money do we have, how much has been spent, that it be declared in writing, but to the ENF committee, I guess it would be more proper jurisdiction. Then it also codifies the executive order, which makes the 5% dividend applicable only to counties that are either inpatient and/or outpatient CHS provided by someone else other than Cherokee Nation in the 14 counties. So that would include Delaware, Craig, Nowata, Washington, Rogers, Mays, Wagner, McIntosh, and Ottawa. It would include 11 of the 14 counties. And that's already true under the executive order, but this would codify it to make sure that we have something to stand on should there be an issue. Then it also sets aside that funding from the 5% could be used to, because my personal feeling, I have not consulted with Connie, other than I just provided it to her what I was asking for, that if needed, that we could ask for additional, they could have staff, additional contract health service staff out of the 5% set aside if they were not able to provide for it under their existing budget. Because I know I personally generate a lot of email traffic and otherwise on these issues, and it seems like a lot of pressure on Brett Hayes and his staff, his team. And then it provides for the automatic appeal on behalf of a patient, and that's it.
Okay.
So I make a motion to approve.
We have a second.
Second.
We have a motion and a second. We have any comments? Yes.
Okay, so what I think I'm understanding is that you want to leave out Cherokee County, Sequoia County, and Adair County, is that correct?
The way, thank you for the question to clarify. So the way I understand the executive order, that is already the case. When you look at the reports, and I think we've had this on the books for like almost 3 years, they continue to be served because those 3 counties, of course, are both inpatient, outpatient Cherokee Nation Contract Health Service at 97% and above. And we've been given indication over and over again that the remaining 3% or so are things that regardless of how much money we have, we would not approve those. That is the way I've been told. So the executive order issued by Chief Baker already sets aside the 5% for the 11 counties only in those areas where they're not already covered by contract health service. So for Delaware County, for example, that would be inpatient contract health service would be under the 5% set aside, that outpatient contract health service is already under Cherokee Nation. And then that would be the same for Mays County, and then it's a mix as well, I believe now in Craig and Nowata County. And then it's a mix in Washington County. Rogers and Tulsa County are the only 2 that have both Claremore IHS hospital inpatient and outpatient. And they're the complete opposite of Cherokee, Adair, and Sequoia County.
And you want to take a portion of service money and use it for utilization of hiring staff that no one's even requested.
It allows for them to do so if needed, because we're having trouble getting responses sometimes at this rate, because I think the caseload has increased considerably. It doesn't mandate that they have to, just that if they need to, they could take it from this money, and it would authorize them.
So the money was set aside for eyeglasses, dentures, prosthesis, cancer treatments, hearing aid, contract health services, but now we're going to use part of it for staff?
If needed. We don't have to do that part. If you're offering to strike that sentence as a friendly
I just want to make sure that I
amendment.
understand what you're trying to do. Take service money and use it for employees.
Well, what we're seeing today, we're not mandating that anyone has to hire, but what we're seeing today from my take when I talk to my constituents is that the response time is not adequate for some of the services needed. So it's great if we have the money there, but if someone's dying of cancer and we don't have the staff to administer it, I'd rather make sure that we have staff to administer it, and there's a balance. We're always
Okay.
gonna have a trade-off.
And explain the last part of the change. You want them to automatically file an appeal, which will cause more employees. File an appeal on behalf of a patient not covered by contract services to expedite the 5% dividend coverage. Tell me what that is.
Well, because the Claremore Indian Hospital Contract Health Service, for example, and this also applies to the Miami Clinic and as well as Creek Nation Healthcare in some areas. And I apologize, I don't have the breakdown right in front of me. But there's a variety of other entities that also impact the areas within the Cherokee Nation. But I can use Claremore as an example, and we heard earlier what that process looks like. So because we have not compacted the Claremore Indian Hospital Contract Health Service, if we have people, which is a lot anymore, in a cancer situation, they may or may not have an advocate at home on their behalf, we suddenly saddle them with a lot of additional paperwork and stress. And so making it seamless, which it sounds like we have some of that in place now. And if we want to recover some of our money, we need to appeal to IHS. And that can only be done on behalf of the patient in order to make our money go further. I mean, I wish there was a different way to do it. I'm only trying to deal with the hand that we've been given right now to make it best for both our system and our patients. So I think, may we have Connie respond as well? She's wanting to respond, I believe, Madam Chair. Thank you.
Thank you.
And then it comes back to me because I'm not done yet.
I'm trying to kind of get a grasp of what you're suggesting as well so that I understand it. A couple of comments. Once we are able to finalize the compact of those contract health funds in the other counties, there are funds for additional staff to provide those services. So, because we recognized right away that could be an impact that we would have to incur those expenses. So we should have funds to cover that. Also, specifically to address the case management of cancer patients, I think almost every clinic has a cancer case manager. And if we're failing to do that, then if you could give me those specifically, then we can address those as they occur.
So I need to start asking, when I get those patients, for a cancer patient
Case manager.
case manager.
Connie, since you say that you think they all have one, could you send us an email to our respective clinics telling us who the cancer case manager is? Because I would sure like to know down at Redbird.
Yes.
Because they used to have one, but then they didn't. So it's something that's
Yeah.
really needed. And if there is one, I want to know who it is.
Thank you, Madam Chair.
And that would be, in the example you used, Council Lady Watts, that would be your contact person for those specific issues related to cancer. Or we can send them directly.
If that had been shared with me before, I have somehow missed that, and that would be excellent, because these folks are hurting, they're in pain, they're scared, and that would alleviate a lot of email traffic and concerns.
Oh, I completely agree, and
So do you have somebody that's assigned just to our Claremore Indian Hospital patients then?
I couldn't tell you the name of one of them right now. We have over 2,000 employees, and people move, change jobs, and it's usually a nurse.
But you're going to share that with all of us?
Yes,
Thank you.
I will clarify that.
Speaker Jordan, I think it goes back to you.
What it seems to be that we're doing now is we're doing exactly the reverse of what we had a couple years ago. And what I believe we need to do is this 5% money just needs to go across the 14 counties in a fair manner and let the health people decide on a case-by-case basis, which is what they're doing right now. This is going to be exactly a reverse of where we were a couple years ago. When we passed that 5%, or when we requested that 5%, we thought it was going to go across the board. Now, if we do this, then 11 counties are going to get the money and 3 counties are not going to get the money. And I cannot support it in that manner, nor would I support taking money for employees from our service part of our money. That to me is going backwards too. So I can't support it for that reason. So we've got 2 dilemmas here. Do we want to go backwards on both of them? And I don't think we do. I think that our whole idea of the 5% money was to be fair to everyone that needed help with services of contract health nature across the 14 counties. So I cannot be in support of this. Thank you.
Do we have anyone else want to speak? Councilor Watts?
Thank you. If my second agrees, we'll strike the sentence concerning staff. if it's just gonna go directly to services, and I had concurrence, so my motion is to pass the act with the amendment striking the portion for staff, and making it just for, direct payment of services concerning contract health service. Because I also heard Connie say that she had adequate staff or funding for adequate staff. And then it would be up to her and the administration, executive branch, to see if it was administered properly. So, but what I think the point is that the executive order has not been repealed. The executive order states the same thing, that this money is set aside for those not already served by the Cherokee Nation. So this act doesn't change what is already happening. It just codifies it in law, is the way I understand it, because that executive order by Chief Baker has not been repealed. So today we have a continued trend of reporting that 3 of the 14 counties are served at 97% plus under existing contract health service money. That contract health service 5% set aside cannot be used for existing Cherokee Nation contract health service coverage. So this just guarantees to our constituents who are constantly worried about this issue and are served at less than 50% on an ongoing basis by Claremore Indian Hospital and probably Creek Nation in Miami, that they're guaranteed that money under tribal law for the other 11 counties. So it really doesn't change anything for Sequoia, Cherokee, and Adair. They'll still be continue to be covered at 97%. And if that does change, we can go back and address it if funding somehow goes differently. But the Health Committee report shows 97% plus on coverage for contract health service, unless it's being reported to us wrong. So with the amendment striking the funding for staffing, I would like to see this passed today, and I appreciate the consideration of the body. Thank you.
Counselor Jordan, you're next.
Your big problem is where you're not changing, what you're wanting to change, and is the biggest part of the problem here, is funds expended under this section shall be expended to Cherokee Nation citizens who reside within the 14 county jurisdictional area and not covered by contract health. Now, what that means is your people. You've taken out the word, you've added the word any, or taken out the word anywhere. Now, if you want to put the word anywhere back in there, which basically now you don't have a need to change the law at all, then we might want to talk. That word right there means all the difference in the world where you have taken it out. That's where the unfairness is when you strike that word anywhere.
Madam Chair, may I respond? Since
Yes.
it's strict? Okay. So, Madam Speaker, the way that I understand it today is not just Cherokee County, Adair County, and Sequoia County. They happen to be the only 3 counties already only covered both inpatient and outpatient by Cherokee Nation Contract Health Service. They are already under existing tribal compacted dollars through IHS, covered at 97% plus on average. So when the rest of the communities, and even like Delaware or Mays, for example, where outpatient is under Cherokee Nation Contract Health Service, that they would be included, that 97% of them would still be covered. So oftentimes, from the feedback I get from constituents, we don't have these issues in Cherokee, Adair, and Sequoia for contract health, the feedback, unless communication fails. But not because there's not money there for them. So that doesn't change with this law. They will still get 97% coverage. We're not taking any money away from them because Chief Baker has already issued an executive order which does not allow for the 5% to be spent in their areas. Or additional money on outpatient contract health service, for example, like in Delaware and Mays. So people in those communities often know, because very quickly, under Cherokee Nation Contract Health Services, they know that they can go to the doctor and that they need a knee surgery, that they need a hip surgery, that they need a shoulder surgery, the feedback I get. But what happens is, because the inpatient, the hospital visit or the surgery is the inpatient side, and that's Claremore Indian Hospital. That's where they will get denied and they get held up. So they know they need this surgery, but they never receive it because it's not a life-threatening situation. So in terms of IHS at Claremore, that's maybe they can't even fund level 1, which is immediate life-threatening, through a year. They will even defer those payments even though they approved it and people go into medical bankruptcy. So that's where we will see that people are getting approved in those other areas and suddenly under the 5%, which is right now an executive order of Chief Baker. I am simply codifying it so that we can make sure that they are guaranteed those and we can have something to hold our hat on when we're going back and forth on terms of emails and such, and we know that money is being spent for those per the executive order.
Counselor Fisher.
Just a short response. I do not agree with her that once they're denied there, they're not being served, because once they're denied at Claremore, they're coming right into our contract health system. And we're picking them up at that point. We only had 4 denials from their area last month. 4 denials. That's all we had. I don't know where she gets this 50% versus 97%. We had 4 denials. That's what's in the book on page 21. 4 denials is all we had. And I can assure you, we had more denials than that on our side. So I didn't hear anywhere in there where she was going to leave that word in there. So I still cannot support the language that she has in this change. And I hope you all will join me in not reversing what we're doing. We put this 5% money where it needs to go. We're covering those denials at Claremore Hospital. We're right now in the midst of taking over all of contract health except the 1 or 2 people that go into their hospital. I don't see why we need to make any changes. I've got to be honest with you. I think this is political on the part of the 2 sponsors because they have been against a lot of health things that we've been doing the last couple of years. Now they've got to get their name on something that says they're for health. And I don't need a response. That's my position.
Counselor Fisher.
I just want to reiterate what the speaker said. There's 4 denials in the book. On page 22, it shows how the 5% has been spent in these areas. It shows all the communities that it's been spent on, and none of these communities are in Sequoyah County, Adair County, or Cherokee County. It shows all these communities, and it shows Colcord, Foyle, Blue Jacket, Ramona, Wagner, Locust Grove, Sperry, Bartlesville, Oologah, Veneta, Claremore, and Catoosa, Chelsea and Tulsa's the top 5. And I'm not going to take money from all our casinos and earmark it for just a certain area. And I agree with Tina. Since these people were against health, they're going to have to find something that is for health. And I very much think it's political. And what gets me about the whole mess is, no, I better not say what I'm about ready to say. I really don't understand, since it all is going right now towards these areas, and it's working like that, why do you want to change it? Right now, it is going to y'all's areas. It's working fine. Why do you want to put it down in law? Why do you even want to draw attention to it? Because at this point in time, you all make me want to turn it around and make it go to all the counties. Is that what y'all's wanting to fight, where we turn around and make it go to all the counties instead of just your counties? Is it? I'm asking, is that what you all want? Did you want to draw attention to it?
I know the fact that we breathe bothers you guys, but we're here to do a job, and we have consistently been on this issue. This is why we voted against it in the first place, or I did, because you did not remedy the issue. That's why I think Chief Baker then responded and tried to address that the money would go, because before, we limited it only to the areas where Cherokee Nation Contract Health Service had coverage, and we didn't necessarily allow until we had the executive order in place. We work with our constituents every day, and we're trying to figure out how to fix this. We've been through multiple discussions with this body, and it didn't seem to be going anywhere. So the only other option I had was to put something out on the table in order to remedy what I thought was an issue. If you don't like it, vote it down. But don't get into this other stuff. There's no need. We are simply trying to do our job. I know that's hard for you guys to try to do and allow us to do, but we're here and we have another year on this body, whether you like it or not, because we were duly elected by the Cherokee people in our area, and we're here to represent them. Thank you, Madam Chair.
Kara, darling, you think too much of yourself.
Point of order.
Counselor Frankie Hargis.
I just wanted to ask, if the money's going to Claremore to the deferrals from Claremore, why do we need to change this? I just don't understand why you're wanting to change it at all when it's already covering those deferrals that are, that come from Claremore to Brett. And I do want to say that I'm offended by your suggestion that my people get automatic approval, because they don't. I work daily with people who have been denied, and we go month after month after month to get theirs approved and to get their bills paid.
Thank you, Madam Chair. Councilwoman, I appreciate the question about why. So on page 20 of our report, it says that Contract Health Services, out of 5,494 referrals under the normal Cherokee Nation Contract Health Service, are approved, or not 5,344, or 97.3%. So we've asked for reports on what that looks like in terms of the denials. And I apologize if I alluded that somehow there weren't people left out, but what we've asked about, we've gotten continued assurance from the department without details that those folks would not be approved if there was a denial, regardless of how much money we had in the system. So I don't know what those situations are. I'm having to rely on what the staff say. But if you go back to the Claremore Indian Hospital monthly report, which is given to us, then you'll see traditionally we have about a 45 to 50% approval rate, at least in the Claremore Indian Hospital Contract Health Service coverage area. So we are talking about significant numbers of Cherokees that are not getting funded. They're going, if they don't die, we have people that are dying.
We do too.
And that shouldn't happen. So that is a Cherokee Nation Contract Health Service issue that I would hope we would address together with Connie and her staff. If I hear about those things, I'm going to take those issues to her. But I know that the constituents that I work with, that they need guarantees, and an executive order could be appealed at any time and removed without notification or approval of this body. So if 5% set aside is going to be bragged about in the news and declared to our people as available, then I want to give them reassurance that they would at least have a couple of months warning that it would have to go through this body. And right now, they're left with, it could be appealed and removed from them at any time because it is simply an executive order. So this doesn't change what is actually happening right now. It only solidifies it or codifies it and requires it to be an action of this body. And if there are issues with Cherokee Nation Contract Health Service, then we should need to hear about them, and we need to address them with Connie and such. Every Cherokee deserves access to Contract Health Service, but right now 11 of the 14 counties are not treated the same as what I see in terms of delivery for Cherokee Nation Contract Health Services. And that is what is being reported here. The only other situations that I hear about have been communication issues, and if I find those constituents, I immediately get that to Brett and Connie to address, because I don't want to see that either. I agree, and it's very emotional when you get those folks, because they could be cancer. I mean, it could be imminent. I concur with you, Councilwoman. I do not want to see that. But what's being reported to us, unless it's not correct, is a much different picture than these other communities, which is the vast majority of the Cherokee Nation that are not being served by Contract Health Service. Thank you.
Our Secretary of State is.
Thank you, Madam Chair. I just wanted to comment that the notion that the principal chief would repeal an executive order fighting for the 5% is, I think, unreasonable. The principal chief is the man who on this committee fought for the 5% and had to bring a number of his colleagues along for that. The second thing I'd say is anytime an executive order is repealed, it's a public record. An executive order is a public record. This body would have notice if the principal chief repealed 5%. She's not going to have it since he championed 5%. Finally, Madam Chair, I can't stress enough that we are in the midst of negotiating the compacting of contract health services out of Claremore with the Indian Health Services. We're doing what this body charged us with months ago. And so let us finish that process. And I think we can do that without any changes in the law, it seems to me. Thank you, Madam Chair.
Councilor Thornton, you're next.
Yes, I think there's a couple of points here that need to be made. I think first time 5% had passed, it was voted, vetoed. Then some of those people didn't override the veto that voted against it. I think some of them sitting right here. But I can't understand why you would want to change this when you're getting 100% of the funding right now out of 5%. Are you afraid somebody's going to give it to another Indian down here in this district? Muskogee County goes to Hastings. Delaware goes to Hastings. You can name 4 or 5 of these counties. These people going to Hastings, and they're part of that 97%. So why are you hollering about us taking some of this funding if we happen to take it? You should be helping us. I can't understand you, but that's just the way I look at it. And as far as changing the law, my gosh, you got an executive order. What do you want? Thank you.
Councilor Lay, you're next.
Thank you, Madam Chairman, and I think the Secretary brought up one point that I wanted to make. I mean, I understand this legislation, because my constituents are up in that district. But I also understand that Bill Baker is not going to pull that executive order. He's not going to do it. And I got here just in time to help him vote that through, and I watched him sign it. I'm sure proud of that, and I'm proud of this body for doing it. I understand this legislation, but I think that 95% of the situation that we're concerned about, you and I, is just about to be fixed. And I don't want to mess that negotiation up. And I'm thinking that this came at a little early. If that negotiation fails, then let's come back with this, something like this. It's what I'd like to see. I understand the frustration. Thank you, ma'am.
Have any other comments?
You know, I'd like to remark what Dick said. I do believe that's the first thing he signed, wasn't it? Wasn't that the first?
Yes.
Well, if there's no further comment, we need to vote on this up or down. We had a motion for this legislative act and a second. And did you offer friendly that you were removing the part about adding the additional staff?
Yes, Madam Chair, that sentence was removed and struck, and my second, Councilman Lee Keener, did accept that.
So we are ready to vote, and all of those in favor of this act, let it be known by saying yes. Roll call. Dick Lay?
I'm waiting on the negotiations that will fix this act, so I'm voting no.
Curtis Snell?
Morty, yes.
Denise Taylor?
No.
Victoria Vasquez,
No.
David Walkingstick,
No.
Kara Cowan Watts,
Yes.
Jack Baker,
Yes.
Harley Buzzard,
Yes.
Joe Byrd, Julia Coates, Jody Fishinghawk,
No.
Janelle Fulbright,
No.
John Garvin,
Yes.
Frankie Hargis,
No.
China Gloria Jordan,
No.
Lee Keener.
Yes.
Seven yes and 8 no.
So the motion failed.
Thank you, Madam Chair.
Do you have any announcements? The next meeting is tentatively scheduled for Monday, May the 12th. We have a motion for adjournment.
So moved.
So moved, and Frankie seconded. All in favor of adjournment?
Aye.
Aye.